Okay. Welcome everyone to our first Takeda webinar series through SSCD. The topic tonight is on supporting nutrition and social emotional needs of patients with celiac disease. We're very excited tonight to have two amazing speakers, Ann Lee and Janelle Smith. Janelle, you can go to the next slide. So before I introduce the speakers, just a couple of housekeeping items. This webinar has been approved for one continuing education unit for physicians, dietitians, nurses, psychologists, and social workers through Boston Children's Hospital. It's probably good if you take a screenshot of it, but we'll also put it in the chat so that you can see. The way to claim or to check in that you were here is by texting that code 459-242 to the phone number listed on the screen. I will also write everyone's name down because I know this is the first time we're doing this, but that's how you check in, and then we'll email you a certificate of participation after the webinar. All right, and then with that, I'll introduce our speakers. First, I'll introduce Janelle. Janelle Smith is a registered dietitian, nutritionist specializing in gluten-related disorders and disordered eating and restrictive eating patterns in patients with digestive disorders. She's a senior dietitian with UCLA Digestive Health Diseases Nutrition Program and serves as the lead dietitian for the Celiac Disease Program. She's had several leadership positions in the Academy of Nutrition and Dietetics, especially in the group Dietitians in Gluten and Gastrointestinal Disorders, and is former staff at the Celiac Disease Foundation. Ann Lee is an assistant professor of nutritional medicine in the Department of Medicine and the Institute for Human Nutrition at Columbia University, and she's the dietitian at the Celiac Disease Center. She's involved in patient care and research. Her research and many publications focus on quality of life issues, dietary adherence, concerns of nutritional quality of the gluten-free diet, and eating patterns and behaviors. And currently, she is working with an international group to define standards for nutrition assessment, education, and adherence of individuals living with celiac disease. So welcome, and I'll turn it over to the speakers.
Thank you, Megan. Thank you, everyone, for hosting us. I think this topic is near and dear to both myself and Anne. So here's our disclosures for your review. Our objectives for everyone participating today is that you will be able, after today's lecture, to better identify the social emotional barriers to gluten-free diet adherence in our patients, to address some unique nutritional challenges for your patients following a gluten-free diet, to incorporate one or more screening tools into your patient assessments that will help you incorporate psychosocial risk factors, and to be able to provide resources to patients that support their nutritional, social, and emotional well-being. It's a heavy lecture, so we're gonna dig right in. Go ahead, Anne.
Okay, next slide. Okay, when we start, to begin looking at how we are going to support our patients both nutritionally and, in their psychosocial realm, we really need to remember that, and you can click through on a couple of these because it will circle different areas that we really need to be able to focus on, that we need to remember that the impact of the diagnosis and the gluten-free diet is really multifaceted and affects so many parts of a patient's life. And on the next slide, we actually look at, one of the studies we did as we were looking at this multifaceted impact on our patients' lives, we started digging into specific areas. And on one study where we looked at the eating behaviors and attitudes, we found out surprisingly and kind of alarmingly how many of our patients thought about food and eating or their weight often, almost, or always. And that really gave us an insight into how much the diet impacts that day-to-day aspect of our patients' lives. One patient said, it affects my every waking moment. And in looking at how much the diet affects their awareness of their eating and location and where they are and who they're with, we looked at the quality of life scores and found that those that were thinking about their food and weight more often had significantly lower quality of life scores. And on the next slide, we'll see that that led us to look at at another study where we really looked at, these behaviors and how do they then impact adherence, and how do they impact, or again, quality of life, and does it make someone more adherent, less adherent, or even hypervigilant? So in this study, we looked at both adults and teens, biopsy proven. We did the validated quality of life scores. We did a knowledge-based score on validated food labels and quizzes. And then we developed a vigilance score based on a 24-hour recall and in-depth interviews that looked at what kind of questions people asked as they were going out to eat or with their friends. And on the next slide, you can see that on the next slide that we looked at the overall quality of life scores with their subscales and where they fell on this vigilant time, kind of spread. And what we found is that in the adults, there was a significantly lower quality of life score by 10 points, which is a significant major shift. The teens had lower quality of life, but it wasn't as strongly significant as it was with the adults. We found that higher knowledge was associated with more vigilance, lower quality of life, more feelings of limitations, and increased burden. Interestingly, in the teens, we found, eating out and gluten-free products was their biggest nemesis, really. And we found that 70% of the teens reported a huge negative impact on their gluten-free diet. And that led us to, looking at more things that we can see on the next slide, where we said, okay, if this is impacting behavior around eating and with others, how does it affect now this very social aspect of our life of dating and being with people socially and intimately? And so we did a dating study in which we looked at the ways the diet impacts their dating life, what kind of things people were asking, what they were looking for. And what we found is that there was a major to moderate impact on the quality of life and overall life by females, by age group, by education. And on the next slide, we can see how big that impact was, where it was almost 70% of the participants said that there was a major or moderate impact on their dating life for having celiac disease and having to follow the gluten-free diet. We also found on the next slide that there was also hesitation to go on a date. It was pretty evenly divided whether they were hesitant because of their celiac disease and gluten-free diet. But the one thing that we found very interesting when we asked people, well, if you decided to go on a date, did you ask to do something specific? And the resounding response was anything but eating together, that we will do hiking, drinks, activities. One patient even said, I hate bowling, but I'd go bowling instead of going out to have a meal. And so we realized that that's a huge impact, and you're really narrowing the possibilities of things that you're going to do on that first date. It also highlights that when we think of doing alternatives to grabbing a bite to eat or meeting for coffee, that this also will limit our teens. They're not able to go out and have a cocktail. They're not likely to go maybe to a coffee shop. Where do kids hang out? All the places that are gluten laden. So it increases even further the burden on our teens. And when we looked at the way it affected the preference for where they're going, we also found out that some people, go ahead to the next one, that many people wanted their partner to also be gluten-free. So after that first date and they navigated that, they're like, okay, I want the partner to be gluten-free. We found other people reported that symptoms were sometimes, impacting their ability or their comfort level with being physically intimate. But really crazy, we found that over 40% of patients were hesitant to kiss a partner that wasn't on a gluten-free diet. So this, of course, I always say that, one study leads to another. And indeed, this study, where there was such hesitancy, we looked at a kissing study. And so we developed the kissing study on the next slide, and we can go to the next, where it defines what our protocol was. And so we had 10 couples, one with celiac disease, one without. The participant without celiac disease ate a ton of saltine crackers to conduct the study, but we divided it up where in the 10 couples would kiss twice, but in very controlled and measured ways. The inclusion criteria, they had to be over 18, where they had to do 2 different visits, at least 1 week apart. On the first visit, the non-celiac partner would eat 10 saltine crackers, wait 5 minutes, and then kiss the partner with celiac disease. We then collected the saliva from the partner with celiac disease and measured that. We then repeated it where we collected the saliva from the participant without celiac disease. We then had them brush their teeth, rinse their mouth in between each of these exposures to gluten. And we made that poor non-celiac partner eat 10 crackers, again, wait 15 minutes, clean his mouth, do it again, wait 30 minutes. And then when they came back the next week, we had them drink 4 ounces of water before they kissed. And our results, which are on the next slide, were amazing. We found that the amount of gluten did vary in the saliva of the participant with celiac disease from under 5 parts per million to 153.9 parts per million, but only 2 out of the 20 exposures were over the 20 parts per million. An interesting little caveat, we haven't figured out exactly where this fits in, but the 2 that were over 20 parts per million were in our 2 couples that were not married or engaged. So not quite sure what that says, but it's an interesting little sidebar. Significant, though, is we found that drinking the 4 ounces of water before the kiss reduced the amount of gluten in all participants to under 20 parts per million. So that that was, a really reassuring thing. There was only 1 positive urine test, and that was in the participant that had the 153 parts per million. But interestingly, the urine test was positive, but they reported no symptoms. In the non-celiac partner that ate all those crackers, the amount of gluten in their saliva ranged from 19 parts per million to over 2,000 parts per million. So the results are, in conclusion, on the next slide that we see is that, there's good news. There is detectable gluten in saliva, but it's in a safe range. It would be similar to eating a gluten-free product. We have a lot of people that get very worried about it and will, we have stories where patients will make their partner brush their teeth, take a shower, all kinds of things. But really, drinking 4 ounces of water reduces the amount of gluten in the saliva to a safe and reasonable level. But of course, this study raises more questions. How are we guiding our patients? How are we handling transitions to other parts of our life? For that single couple to being married, for that married couple to having a kid, for that kid transitioning to college. So on the next slide, we see that we started a college study and looking at the transition of our high school teens into college. And so we looked at 15 child-parent dyads where we interviewed the child 3 times in the fall semester. They filled out all kinds of surveys. We interview the parents and do surveys at the end to capture their perceived experiences of the child. And we did validated studies of adherence, quality of life, and self-efficacy. On the next slide, we can see some of the initial results from some of the preliminary results from that initial interview, which was held when the kid was still at spring semester senior year in high school. And what we found here was really fascinating, that even here, most of the teens said that they felt, kind of isolated from their friends. They felt the school was really not supportive at all, that cafeterias did not provide safe gluten-free options. They often had to bring their lunch. And they often felt that it really impacted on their overall life experience and the ability to be spontaneous, which is what teens are all about. On the next slide, we can see too that we looked at the feelings and expectations when they're starting, when they were kind of interviewing their colleges. And, there was a lot of concern over whether the school would be able to provide safe gluten-free food, and the feeling that they were really like our first study, always thinking about food, about the safety of their food, and getting contaminated. Then on the next slide, we start looking at those, managing the diet over time and what happens once they're at college. And we found, interestingly, diet adherence was pretty stable. And there was only really one participant that had a significant change in their adherence score. And it really went into a poor section. What we need to dive down deeper is this kind of the norm teen reaction of being free and wild in college, or is it more a celiac specific reaction that's happening? On the next slide, you could see where we looked at some other measures. We looked at quality of life and self-efficacy, and we found that of the students where we had all their scores completed at this time, 100% increased their self-efficacy scores. And again, it reinforces that this is a time for the kids to grow, but we need to support them. I mean, it's a hard time for them too. And on the next slide, we look at, the self-efficacy when eating out. And again, the scores all improved. So we see that high school kids were really, really struggling. Once they were able to navigate on their own, they had great concerns and great worries, but they were able to rise to that challenge and start, really being empowered and being more able to take, to advocate for themselves. On the next slide, we look at really the quality of life scores, and there was some variation. In the initial semester, in the beginning of the semester, we had 2 that had decreased scores. The others remained all within pretty much the same range. And so we're seeing that we have an improvement in self-efficacy and marginal variation in the quality of life. So what do we take away from this? We look at, on the next slide, some of the challenges, which we'll go back to Janelle.
Thank you so much. Amazing research coming out of your program. So in addition, kind of to add to Anne's research that she presented, we want to talk about nutritional challenges related to accessing food, and then culture, religion, and disordered eating factors that really are going to be impactful. One nutritional consideration, we're not going to be able to cover all of them today, so I just highlighted a few, is basically what happens on a gluten-free diet, and how does a gluten-free diet in people with celiac disease compare to a typical local diet? So this meta-analysis reviewed 10 studies over almost 20 years, primarily from Western countries. But some themes that they found was that overall, those following a gluten-free diet had a higher intake than the typical population of fat, specifically saturated fat, which we know can be concerning for many different chronic illnesses besides celiac. There often was lower complex carbohydrate intake, such as whole grains, starchy vegetables, but higher simple sugar intake, which again may be a risk factor for some inflammatory chronic conditions. There was lower fiber intake in the gluten-free diet, as well as lower content of several key vitamins like D, E, and several B vitamins. Also lower content for key minerals, all essential to health. And us as dietitians were kind of not surprised by this, but it's really good to see these themes replicated across several different studies in several different countries. One reason for this is a unstandardized or lack of fortification of gluten-free carbohydrate products, such as this study that found compared differences in the nutritional quality of gluten-free breads and pastas in the UK. There is some variation in terms of which products are fortified with with vitamins in grain products in the US. We'll talk about on the next page, but in much of the European Union, there's not fortification. So a lot of the gluten-free products that may not be made from whole grains are just naturally going to be less nutritious. So again, comparing somewhat reasonable products, 61 standard versus 49 gluten-free, there was significantly less fortification of micronutrients in the UK and significantly higher cost, which is also seen throughout many different countries. In the US in particular, there is fortification mandated in all of the grains that are on the left, most of which are gluten containing, but not all. So some of our patients in the US at least could get extra vitamins and minerals in whole grain rice, cornmeal, corn grits, and breakfast cereals made from those. However, a lot of those grains may be at risk for cross contact if they are not labeled gluten-free, especially the breakfast cereals, for example. Everything on table 2 is not required to be fortified. So essentially all of our gluten-free grains may or may not, have their full nutritional value, but they also will not be fortified with adequate folate or iron, which a lot of Americans rely on to meet their recommended daily intake. Then we have an issue of food insecurity. Some studies kind of in the past 10 years have been examining this in many different countries and showing that food insecurity is a significant problem in patients with celiac disease, and it negatively impacts adherence to the gluten-free diet as well as quality of their diet nutritionally. So this study used NHANES data in the US between 2009 to 2014, and it found that approximately 1 in 6 people with celiac disease were food insecure. People who were younger, had lower education levels, were non-white, had lower income, were more likely to be food insecure, and all of these people were significantly more likely to be non-adherent to the gluten-free diet. They were less likely to have adequate intake of protein, carb, fat, and vitamins and minerals. And specifically, less than 25% of these food insecure patients were considered adequately adherent to the gluten-free diet. So 75% were not, which is really concerning. Just to throw it out there, I guess I didn't include it, but there's a lot of studies that replicate this data outside of the USA as well. So next, another nutritional consideration is how food serves for social connection, culture, religion, and food-related quality of life, some of which Anne really highlighted in all of those studies. A couple other themes that came up from some other literature outside of the US was having a lot of barriers interpersonally with family and friends. So this chart kind of shows several different other interpersonal challenges, such as family members or spouses asking their celiac partner to eat gluten-containing foods, in-laws, the impact of how in-laws are supportive or unsupportive of the diet, friends and family. So kind of beyond also these like dating situations, there can be really significant impact of how pressure and support from people around the individual really negatively impacts that person's adherence to the gluten-free diet. So overall, I would say that, there's definitely concerns about decreased food-related quality of life and decreased adherence to the gluten-free diet if our social, emotional, financial needs are not met in our patients with celiac disease. And so next, I want to talk also about the increased risk for disordered eating, which needs to be elucidated further, but I guess in my professional opinion, can be really related to the decreased adherence and food-related quality of life. So studies lately have showed a significantly increased risk of disordered eating in people with celiac disease. Overall, there is a significantly higher prevalence of disordered eating and eating disorders in any GI disorder, but especially those like celiac disease who really are required or encouraged by health professionals to be vigilant and mindful of their diet are at increased risk. Other factors that increase risk of disordered eating in people with celiac disease includes how long they've been on the gluten-free diet. So if the diagnosis has been made more recently, that person is more likely to struggle with their eating behaviors in terms of body image, adequate nutrition, obsessive thoughts about food. Also, if they have more symptoms, they're more likely to have a disordered behaviors with food. And if they have a poor quality of life, they're more likely to have disordered behaviors, which may be a chicken or egg situation. This slide kind of just demonstrates again all the different factors in someone with celiac disease that may kind of predispose someone to disordered eating, such as pain, discomfort, dietary vigilance, diet misinformation, pressure to be adherent, as well as body image changes that arise both from a diagnosis that can take someone from one body size to another because of changes in absorption or changes in their eating habits, but also just from being more aware of food. Some people actually turn that energy inward to themselves and how they view their own body. In addition to body image and opinions on weight and eating behaviors, it's becoming increasingly apparent that a new eating disorder called avoidant restrictive food intake disorder is likely very higher prevalent in people with celiac disease. So this eating disorder is not particularly centered on a patient's body weight or body image. It's more around fears around the food that really impact that person's eating to the extent that it either manifests as inadequate food intake or it really limits their psychosocial functioning. So this study surveyed 137 adults and with celiac disease and kind of highlighted their different reasons for restricting food intake beyond what's medically necessary in terms of gluten. And some top themes were a fear of GI discomfort, including symptoms of irritable bowel syndrome. So maybe many people with celiac disease may continue to have symptoms of bloating, diarrhea, constipation, etc. And those are more likely to avoid eating in order to try to control their symptoms. There's also a higher prevalence of picky eating, meaning not liking a lot of foods, poor appetite, fear of choking, and then we've also, fear of vomiting, like emetophobia, but also, I don't know if you see this a lot in clinic, Anne, but a strong desire to only eat healthy foods that is really brought on by starting to pay attention to food labels and what is gluten, what's in a gluten-free diet, etc. So again, those are many of the different nutritional concerns that we have for our patients. So next, we're going to go into lessons for healthcare providers. Um, First, I want to address the nutritional adequacy. So this is, I thought, a very nicely done paper by Cardo et al. In 2021 that really outlines all the different factors that we can address as providers to promoting a balanced gluten-free diet in order to address kind of the shortcomings that we've seen. But in addition to this, I want us to keep this slide in context with all of the other factors I mentioned: food insecurity, family culture, social support, and mental health and disordered eating risk. Because if we just give people information and say, oh, well, you should eat more quinoa, and that person doesn't have enough money or doesn't have a food environment that even has quinoa at the store, are we even helping them? And are they more likely to internalize that as a personal failing that could lead to poor psychosocial functioning? Overall, we want to increase consumption of more plants and more whole foods that have more of the inherent vitamins, minerals, fiber, polyphenols. This kind of falls in line with a lot of recommendations for a Mediterranean diet, but really any culturally appropriate diet changes that promotes all the different food groups ideally is going to be more nutritious than a diet that is solely, gluten-free packaged foods. Saying that, however, really assumes a lot about that person's access to food. So we may need to not focus on processed food consumption and instead focus on what food is available to them and what food um, fills in the nutritional gaps, even if it is processed. So as dietitians, I think we get really creative with doing that. But I think just important as providers to not say, oh, you should just avoid all processed foods. That's not going to be appropriate for every patient. We could also guide patients toward products that are fortified and enriched with those missing nutrients. We could suggest supplements if they don't have access to those fortified foods, especially things like legumes and diversity of whole grains are kind of underutilized in the American diet, but they are somewhat available if someone has access to cooking them or has access to canned forms of those. So adding legumes can be a low-cost way to really increase the nutritional value of someone's diet that's gluten-free. And this last point is continuous supervision of patients really increases their adherence to the diet, their quality of life, and the way they adapt to the diet, as well as the quality of their diet. A couple screening tools that I think I would recommend we consider using as providers, which I will be the first to admit I don't use this one, is to screen for food insecurity. A really kind of quick screening tool is the hunger vital sign, which is just 2 questions that can really significantly identify people who are at risk. So the 2 questions are, they're on different lines. One is, within the past 12 months, were you worried about whether your food would run out before you got money to buy more? Or 2, within the past 12 months, did the food you bought didn't last and you didn't have money to get more? Patients ideally would answer these confidentially and mark as never true, sometimes true, or often true. And any answer on one or both questions that is sometimes or often true is a positive flag for food insecurity and really alerts you to tailor your recommendations to meet that person's needs, as well as maybe have a lot of empathy for any diet non-adherence that they may have going on. Other resources that I think we need to be offering as providers is referrals to GI psychology, um, support groups if we have those within our institutions or if we have a referral list for those, suggestions of places to access gluten-free food. And then perhaps we could be involved in systemic changes, such as promoting the fortification of all grains and gluten-free packaged products in the US, or providing financial subsidies for access to gluten-free foods for our patients with celiac disease, or promoting food environments that have fruits and vegetables and nuts and seeds at affordable um, levels. I can dream. Um, Next is to screen and prevent disordered eating. So first step would be screening for disordered eating risk. And I would recommend a couple different short tools. One is called the SDE, Screen for Disordered Eating, and another one is called the SCOFF, SCOFF. Both of those can be really quickly put into a patient assessment or note to help us understand. Again, if patient has an increased risk for an eating disorder, they are more likely to be non-adherent to the gluten-free diet. It's really important we don't make the gluten-free diet about weight. Um, Promises that you'll gain or lose weight on a gluten-free diet, or morality, that you're, a good patient or a bad patient for being adherent to a gluten-free diet. Overall, we need to offer an environment of enough food options to explore what their favorite foods are and find safe alternatives for them. Also to use language to reframe their relationship with food, and explore any fearful situations that may be kind of distorted in terms of their fears around food. So I'm going to pass this back to Anne to share her lessons for the clinician.
Well, and it's really based on, Janelle, that was so great, because the paper by Makarai talking about the barriers, the Cardo paper, really are what has informed the lessons we need that are going to influence our clinical practice. So we'll start going through them. If you go to the next slide, our first lesson really is to look at, on the next slide, promote, as you had mentioned, that ongoing involvement of the dietitian. We have found that it increases adherence, it increases quality of life. It also allows the dietitian to monitor for food insecurity, for changes in the person's life and food environment. And we need to think about it in multiple ways. We need to think about the kind of ongoing involvement that you need for a pediatric patient versus an adult patient, the kind of involvement that you would need for the person that's newly diagnosed versus someone's been diagnosed for a while, and then also to meet people on their safe space. Are they more comfortable doing a video visit? Are they more comfortable coming in person? And we need to really connect with the person on their level where they are, And the second lesson that we had is really beyond, promoting ongoing treatment. It's what we do when we're seeing our patients as dietitians and healthcare providers. We really need to conduct assessments that are going to then influence and determine what our approach is to teaching and counseling this patient on the gluten-free diet. We really, as the behavior paper out of India did indeed highlight, we need to really assess the patient's food environment. What is the living and housing situation? I know it may sound crazy, but I have some patients that do not have a kitchen or a cooktop, and we need to know that. So we need to really be detectives and to really dig deep into, as Janelle said, the religious practices. How does that influence intake? Food traditions. Does grandma always do the cooking? The financial limitations. Is that kitchen shared in a multi-generational house? All these different things, we really need to get in and look at that, because then that will inform how we're going to proceed with our counseling. The second part on the next slide to this lesson about assessment is we also need to not just hand that one diet sheet and look at what the food environment is, but we need to continually assess the patient's knowledge, beliefs, and attitudes around that gluten-free diet. Do they understand the consequences of not adherence? If they don't understand, how can we explain it? How can we make it where it is something that they comprehend and the whole family comprehends? It's not just the patient. I often tell my patients, bring whoever you want. It's a family affair. It's not counseling in a silo. We must involve everyone. And we really need to make sure that we're, looking at, real life versus relief. I mean, often our patients, they get diagnosed and they're thrilled. They have an answer as to why they weren't feeling well. But then we have to walk with them to move forward. We have to let them know that this is not a diet where you can take a day off or a holiday or a vacation. And we need to really monitor for those changes in that adaptation to that strict need for adherence. And as Janelle pointed out, that they're not then trending towards, restrictive behavior or maladaptive eating approaches. And the other part of this is we also need to be very aware of their attitude towards food. Especially we have some foodies that love food, and now we're making food almost the enemy for them. So we really need to work with them so that they enjoy food in this new light too. I find sometimes role playing with our patients helps them learn how to navigate how to order, or how to kind of tell Aunt Sally that you love her dressing, and at Thanksgiving, but you can't have it. So we need to be able to really walk with our patient to help them navigate their new life. And the third one is really looking at the psychosocial issues, as Janelle so well described, and really it's so important to monitor these patients going forward. And I really worry about our teen patients, because their life revolves around their social situation. And we really need to make sure, are they developing avoidant behaviors? Are these emotional issues and concerns affecting their quality of life? How is it affecting? Are they feeling like a bother? Do they feel isolated? Are they shameful by requesting their parents buy special food that they may be struggling to afford? So there's so many parts of this that we really need to think about and incorporate these things into our assessment and our counseling. And the fourth lesson is really, to consider our best practices for behavior change. Let's get back into our educational mindset and really consider how important it is to counsel, and counsel well for motivational change. In working with our student dietitians and our interns, one of the first things I tell them is counseling is not a spectator sport. You have to get in there and get knee deep and dirty, because the only way you're going to be effective is to really get to know your patient, and really to be able to empower and motivate our patients and understand their needs, so you can help them develop the skills to monitor that. And then that's really leads into the next lesson, which is communication. We need to develop good communication with our patient and our peer. They need to, we need to talk with them well and understand where they are, but we need to help guide them to communicate their new dietary needs to their family, their healthcare team, and their peers. And I know it's kind of funny to highlight Jumanji, but I always think about the one scene where, Ruby Roundhouse is on the ice cliff with Dr. Bravestone, And he says, well, I couldn't reach out because I was so afraid. And she looks at him and says, when you're afraid is when you need your people. That's when you need them most. And we need to let our patients know they've got their people. They just have to identify them and find them. We as the healthcare team should be part of their people, supporting them along the way. And as Dr. Sotomayor always says, ask. We need to teach our patients and empower them to ask the questions. If they're out, ask the questions about how something is made. If they're somewhere and they're not sure, or they're not sure how someone's going to handle it, we need to encourage, empower them to be brave and to be different, and to identify their team, their tribe. And the last lesson is really one for, on the next slide, is really one for us. We need to expand our network. We need to make sure that we're not treating our patients in silos. We treat our patients from the microbiology cell up to the entire psyche, but we need to be able to communicate that with the entire team. We need to not treat them alone. We need to really encourage, reaching out to social workers, psychologists, whoever the patient needs, and we need to communicate well with them. And on the next slide, we really look at, where do we go from these great lessons that Janelle noted, and these last few, that what do we do next? We have to put it into action. And that's, as Megan had alluded to, we're now working on this international project of developing, standardized assessment, education, tools, so that we can share them with all of our providers. It really came out of the GluTech project, where we realized, that we're doing a multi-center study, and the 4 dietitians at the 4 centers, none of us said the same thing to our patients, which highlighted to me, we need to do something different. So on the next slide, you can see that we really, look at the bottom line, is that we know our patients don't have great adherence rates, but we need to dive deeper than that. We need to, as Janelle said, look at why they're being non-adherent. We need to help them identify things that motivate them, the barriers. We need to promote self-efficacy, and we need to make sure that, is it not adherence, or is it an inadvertent or a lack of knowledge? And so on the next slide, we really see that where we need to go next is to identify those barriers that affect compliance, and guide our patients through them. It's social occasions, it's religious beliefs, and all these things really do impact how well a patient can navigate the diet. And it drives me crazy when a patient comes in and says, well, I was told to Google the diet, that would do it. And it's like, well, Dr. Google isn't the same as having your healthcare team providing you support and education. And so with that, our solutions are, we need to be based in science. We need to not create, as Janelle said, food phobia, where people get so worried about everything that's in a gluten-free packaged bread, that we don't promote disordered eating. We need to really create programs for our patients that educate and support, and realize that the assessment and education has to be individualized for every single patient. It needs to be standard, so we're all saying the same thing, but it's got to be individualized for that person. And we have to continue to follow our patients. So with that, on the next slide, we really can say our conclusions are, nutrition research is cornerstone of changing clinical practice. And that's why all of you attending are so important, to take these lessons and move forward with them. And, I really encourage you, when you think of counseling, think of it as giving your patient a map to navigate their life.
Great, thank you. Anyone can feel free to come off of mute and ask questions to the speakers. We have a few minutes. I am just going to share quickly the closing slides. Let me just, all right, can you guys see that okay? So while people are waiting to ask questions, I'm just going to leave this here. We do have another webinar coming up on November 18th, which is, the topic is advancing opportunities for celiac disease clinics and centers. And the information is on the webinars page of the SSCD website, so you can find that there. Thank you, Anne and Janelle, so much for that amazing presentation. I know that we have a couple of questions came in about the CE credits and the phone numbers not registering. We are going to email Boston Children's with the attendance and make sure that this is set up correctly for next time. But I think if you don't have an account with Boston Children's, you might not be able to text the code. But that's the only information they gave us about how to get to claim credit. So we'll figure it out with them. I've been taking attendance and I will make sure everyone's credits are loaded properly. Okay.
I'll ask a question just to get it
Yeah.
started. What is the, I should know this and I don't, but what is the pushback from fortifying gluten-free products? Like I always have kind of wondered, what are our barriers? I think Janelle brought this up to having some of those gluten-free products fortified with the micronutrients that are lacking.
Do you want me to jump in on that one, Janelle?
Yeah, I don't have that history. I think you do.
Yeah. It's a lot of it's cost. A lot of it's cost. But it's also the fortification will change the texture and the product, some of the product quality. So when you're adding things like a calcium carbonate or something, or the B vitamins, it will change that dynamic property and quality of those baked products, and so it will affect it. But for many manufacturers, it's cost and it's not required, so they're less likely to incur that added cost. And from the manufacturer's point of view, they often say that if I'm adding more cost, my product is already more costly than a non-gluten-free product, that it just will increase that barrier to that patient.
I have the questions. Thank you so much for those two great talks. About the RFID, do you think that some of the RFID cases could be avoided with better counseling at the time of the diagnosis? Because I often see people who kind of like start avoiding corn, start avoiding like lots of foods because they're having symptoms with anything they eat, while in fact at first they had an enteropathy. So they have secondary food intolerance, they are constipated. So do you feel that some of the cases that are flagged as RFID, in fact, at first did not have like good medical like follow-up counseling, and then they started in that spiral? Or is there most of the time a more like psychological like thing underlying all of that?
We the data to answer this question is emerging, so I can't say for certain. But I do think it's a both. It's a dialectic, and so patients who do self-led and elimination diets, such as adding on corn or soy or coffee or whatever the internet says, are more likely to, like in the literature, to develop pathological food avoidance and disordered eating. But also patients who have an anxious or pre health condition are also more likely to take the information in a maladaptive way. But my sincere belief is that the way we intervene as providers has a very significant impact. Whether there's one paper out there that calls it iatrogenic disordered eating, that what are we doing as health providers that actually initiates or triggers or promotes the disordered eating versus what can we do that's protective. And Dr. Adams and I think actually were co-authors on a paper that discusses kind of everything we can do to protect and prevent disordered eating development. So hopefully the literature will show that, but we don't really have the follow through yet.
Yeah, that was exciting that we got that into a pretty big GI journal. So hopefully that starts bringing awareness, I think is the first step that you guys have highlighted. But we have a pretty big interest in that in our clinic and are trying to look at different ways to screen for it. And the screeners probably aren't great that, you know, we have existing now for celiac disease and then different therapies.
It's so nice to meet you face to face.
I just want to say I really appreciate Janelle in sort of like taking on the sort of there's all these goals in gluten-free diet. Like it should be how you should have all the whole grains and all the like you should be eating whole like not having gluten-free products and then the reality of people's lives. I feel like it's nice to hear that like, yeah, you can't always just go in and be like, you should be eating all these fruits and vegetables because they're when they tell you the reality of their day-to-day life, you're like, there's so many barriers to even doing the gluten-free diet, let alone trying to make a healthy version of it that you're like, okay, you're not having gluten, I'm good, kind of thing. So it's I don't know, it's nice to kind of feel like see that in the lit that like it's supported to kind of be like you have to meet patients kind of where they are.
Yeah. That's so true, Joanna, because I think as Janelle said before, it's patients will start saying, well, if I'm going to be healthy, I'm going to be really healthy. And they, just really go down a rabbit hole of we're not going to eat anything processed or anything that has a gum in it or anything that's, and the list gets crazy where it's just like, and I worry very, very much where some of the parents will start saying, well, if being gluten-free is going to help my kid grow, now I'm going to do all this other stuff. And I really, it can be so destructive for that child to then be forced into this eating pattern that's restrictive and isolating. And, just it's not even nutritionally great as it goes. They need to be a kid.
Well, and on that note, I was wondering if you could share some of your strategies for when the mothers are or the parents are really anxious about their kid going to school or going to birthday parties or like social settings, like what I guess because you don't want to project that stress onto the child, but the child still needs to be equipped. So how do you handle that?
I actually sometimes will ask to meet the parents alone first and really work with them and then afterwards meet with the child because I want to make sure that we diffuse the anxiety and stress of the parents so that we can really without the child being there really kind of talk about these are these are the this is what celiac disease is, this is the diet, tell me more about how your family interacts, how can we make that work, but then also let's remember that we're doing gluten-free for the health and well-being of your child, but we also need to consider the psychosocial and emotional well-being of that child. And if it means that they're going to eat a gluten-free cupcake once a week because that's what they do in school, they need to have a gluten-free cupcake once a week. And it's okay, and it's okay to have a gluten-free version of a hamburger and fries. It's really going to be okay. And I often will ask the parents to go back and remember when they were in school and how did they feel. And especially for the teens, it's like, oh, how did you feel about dating? I said, now try doing that gluten-free. Think back to how you did that. And sometimes we get some very funny stories, but sometimes that does help kind of ground the patient back, the parent back into, yes, it needs to be gluten-free, but it has to be real life.
That actually just brought up another question that I have. As far as like, especially when at our clinic it's all adults, but a lot of times people will bring people with them, which, like you said, you encourage people to do. But in cases where you do want to kind of maybe there's something in the relationship that you do want to kind of separate out, is there language that you use to kind of delicately say, like, do you want to meet like I sometimes, between parents having like maybe putting weight issues on their kids or spouses maybe not supporting, or not kind of like exhibiting a certain support. I see people where they come in with their support systems and like it's the support system that's making them too restrictive or the support system that is talking about it like it's not serious in one direction or the other. And I'm just curious like how you approach that.
Often I'll say, we'll do a counseling session, and if you kind of note that things are not well balanced, you can offer, I know it's hard to get everyone here together. Would you like to individually, and that's where we'll say, instead of a video, would you like to come in where it may not be possible for them both to actually physically come into the office? So you're giving them options or avenues where they can select to be seen alone. and then that way they can kind of navigate that way. I've had one couple where one of the spouses insisted on being there. And I finally told him, I said, you know what? I need to talk to your wife alone. We need to have a girl talk. I don't need you here. And he was just kind of like, oh, okay. But I had to be that blunt to say, I need to talk to her and work with her. And then I actually met with him individually to work with him on it as well.
Great.
Yeah,
Thank-
sometimes I'm very directive of like, okay, now I need you to leave the room. I'm going to have a few minutes alone with the kiddo, and then I'll bring you back in about 10 minutes. Okay, thanks. Like, like steamroll them.
Very good.
That's great.
Sometimes it's nice to instigate hard conversations in the session too, if you feel equipped for that, because sometimes people don't talk about these things directly, and you can really be like a nice vehicle for that. Like sometimes I will ask parents like outright, like, do you have any concerns about your child's weight? That's when it's not in front of the kid, but I will directly ask them, because a lot of people are legitimately concerned, and I want to address it with them rather than like tiptoeing around it.
That's so important, Janelle, because with because I see a lot of teens for some reason. I get all the teens. I will actually, in front of the parents, start talking about kissing, dating, alcohol, all kinds of things, because they need to know. They need to know. Their kids are doing it. They need to know. The kid needs to know what's safe and what's not. It sometimes raises some interesting discussions, but
All right. I think does anyone else have any last questions? Well, thank you so much for being here, and Janelle and Anne for sharing this presentation. Learned so much. I always do from you too. We
a
will
pleasure.
see
Yeah.
everyone next month.
See you
Thank
then.
you.
Thank you very much.